Hello, everybody. Um, as you know, I'm recording today's lecture. First, let me move myself so there's no light in your eyes. Yes, I apologize for having to do this and how this last week has gotten all weird. A death in the family, which throws things off, as you know, as you probably know, as I hope you don't know too intimately. Anyway, so one last lecture today, and then afterwards I will go over the test tips that I had sent out yesterday. So we were talking about the personality disorders, and so far I'm not going to repeat everything I said about them, but you recall there are currently 10 of them in the DSM-5. We went over all of them to some extent on Monday, and you'll notice they also are thought to, be categorized into three clusters, or at least that's the way they do it. They categorize them into these three clusters: the odd eccentric cluster, the dramatic emotional or erratic cluster, and the anxious fearful cluster. Again, see last lecture for details. So, this is the way personality disorders have always been conceptualized by the DSM. In other words, there are specific personality disorders. Uh, each is associated with a list of symptoms. You have to have a certain number of those symptoms to be diagnosed with uh, that personality disorder. Now, we talked at the end of class about some of the problems with this DSM approach. And I'm just going to repeat that to lead us into the alternative. So, one issue is that, when it comes to diagnosis, we'd like to think that psychiatrists, psychologists could reliably diagnose people with one of these personality disorders. But turns out they're very difficult to diagnose reliably. And what that essentially means is that a given person could be diagnosed differently by different mental health practitioners. Okay. And some of them seem to be so difficult to reliably diagnose that there is some talk about maybe eliminating them or replacing them in the next edition of the DSM. Particularly histrionic, schizoid, paranoid, and dependent. Um, all right, so that's a problem in and of itself. All right, it's not like other mental health disorders are all remarkably reliably diagnosed, but the problem is particularly acute with personality disorders. Okay, then there's the whole issue of the fact that, we do the best we can, but this deal with 5 out of 9 symptoms or 4 out of 7 symptoms, it's a little arbitrary, okay? Someone with 5 of the symptoms is not remarkably different than someone with 4 of the symptoms, but only one of them would get a diagnosis. There's also a lot of overlap between the syndromes. In other words, if you look at the symptoms of the different personality disorders, you can even see it in the slides from the last class. There are some symptoms that different disorders share. That, of course, adds to the lack of reliability in diagnosing them. And, consistent with all of this is this idea that there's lots of within diagnosis heterogeneity, which basically means that different people with the same personality disorder diagnosis might not have all that much in common, might look very different. Uh, and I sort of went through that last time. If it's 5 out of 9 symptoms for example, borderline personality, that means you could have two people, each who have 5 symptoms, and therefore get that diagnosis, but literally have only one symptom in common. And the upshot of all this is that this is probably one of the reasons why the most common personality disorder diagnosed turns out to be something called not otherwise specified, which is kind of like, punting, kicking the can down the road. We'll figure it out eventually. But right now, we just know the person seems to have some pervasive personality problem. Well, your textbook mentions that starting with the last DSM-5, there's a section in there, an appendix, that describes an alternative view of the personality disorders, a different way of thinking about personality disorders that some people in the field are really pushing as this should be the approach that we take because it gets around some of the problems that I just described. Okay. And it's sort of based on the idea that, well, how do we think about personality usually? We think about what people's personality traits are. So if somebody has a personality disorder, maybe we should think of the disorder in terms of those traits that we in general use to describe human beings. Um, but here, probably too much in that slide, here is what it looks like. Okay, the alternative way of diagnosing personality disorders based on a different way of thinking about personality disorders is, first of all, as we've said repeatedly in this class, we shouldn't say that anybody has a disorder, okay, unless they're having problems, unless they're not functioning well, okay, unless they're having interpersonal difficulties, unless they're very unhappy. So, criterion A, the first criterion, and I'll show you the measure that's involves a measure that just basically tells you how severely disordered is this person's personality, or how severely is this person's general way of behaving causing them problems in everyday life. And theoretically, this measure is not specific to any particular kind of personality disorder. It's just sort of a general, how bad is it? All right, now, the second criterion that I'll show you in a minute in more detail uh, involves measuring those maladaptive personality traits. Okay, so, okay, once we know someone has a personality disorder, we want to know more. We want to know particularly what is this person's personality style. And that's where criterion B comes in. Again, it focuses on traits and particularly looks for maladaptive levels of those personality traits. So I'll show you the measure in a few minutes, but for now, I mean, the one thing to notice is that if you use this system, there are no longer discrete types of personality disorder. There's not like you're borderline, you're this, you're that. Um, Instead, each person would have a unique profile. In other words, you happen to have these maladaptive personality traits. You happen to have these maladaptive personality traits. And the treatment would focus on addressing those traits. Doesn't mean that you might not end up seeing similar patterns in personality disordered people. You might, it might not all be random, but in the end, you have uh, just measures of these things. Okay, so I keep saying, well, there are maladaptive personality traits, and for criterion B, we measure those traits. Well, these are currently the maladaptive personality traits that you would measure if you use this approach to trying to diagnose personality disorders. There's negative affect. Okay, some personality disordered people And one of their issues is just feeling bad. There's detachment. For some people with personality disorders, there is instead or also an issue of just being remote from other people, okay, being disconnected from other people. Their third one is antagonism, okay, because sometimes personality disorders are associated with having a lot of conflict with other people. So you remember when we talked about, for example, antisocial personality disorder and borderline personality disorder. Those both involved a lot of conflict with people, antagonism towards people. Fourth one is disinhibition. That's like the fact that reflects the fact that people with disordered personality, sometimes one of their issues is they just don't censor themselves. They behave in inappropriate ways. So that might sound like people who would be diagnosed as having histrionic personality disorder, for example. And finally, psychoticism. You might also remember that when talking about the personality disorders, one of the symptoms floating around was sort of disordered thinking. Not so disordered that you would get a diagnosis of schizophrenia, but you will remember schizotypal personality disorder, which involves some kind of distorted thinking. And frankly, borderline, once again, uh, also involves this. So you would have measures of these five traits. And you could have a person who's like really not doing well, and they're high in negative affect and high in antagonism and high in psychoticism and low on the other two, or somebody else might instead just be high in detachment and psychoticism. But each person would have an individual profile. Now, by the way, I said that this way of thinking about personality disorders, involves the idea that, well, we usually describe people with traits, so why not use traits to think about and diagnose personality disorders? And though some of you may have noticed this, or maybe not, but you remember when it comes to just normal personality, normative, everyday personality, I've mentioned a few times that personality psychologists think about personality often in terms of the big five, the big five factors of personality. So, forgetting mental health disorders, if we just want to measure people's personality, there are measures that say, look, you can do a pretty good job of doing that with just five traits. And those traits are neuroticism, extroversion, agreeableness, conscientiousness, openness. You might recall that if you took Psych 393, personality, or maybe from your intro psych class, and we've mentioned it as well in here. And so, I have to point out that each of these maladaptive personality traits are sort of, in a way, an extreme, unhealthy version of just a normative trait. Okay, so some people are higher in neuroticism than other people. That doesn't necessarily mean you have a mental health disorder, but the negative affect dimension gets at extreme levels of neuroticism. Okay, so extroversion, okay, the opposite of extroversion is introversion. Some people are introverted. That's fine. But at its extremes, it gets to become detachment. And once again, with agreeableness. All right, that's the way we think about people, but some people are not very agreeable. They can be a little rude, but probably not usually to pathological levels. But antagonism gets at sort of extreme low agreeableness. And, same thing with conscientiousness and disinhibition. People are conscientious, follow the rules, obey norms, the extreme low end of conscientiousness gets us into the kind of disinhibited, unregulated, out of control behavior that we might see in a personality disorder. Now, the least obvious connection is the last one. One of the big five traits is what is called openness. Sort of open to unusual ideas, being creative, being imaginative, which is fine, which is great. But you might think of psychoticism as like the extreme high of openness. You know, it's interesting to be open to the idea that, huh, other people might see things the same way I do, or lots of things that are interesting thoughts to have about other people, but being open to the idea that all other people are out to get me, well, that's, you're certainly being open to unusual possibilities, but that's sort of at the point where you're losing touch with reality. That would be high psychoticism. So these traits are just kind of like versions of the big five personality traits. So you might say, well, why don't we just use a standard measure of the big five traits? We already have those. Personality psychologists have those. So we'll just administer those and see who has unusual scores on those. Well, problem with doing that is that when you're looking for personality disorders, when you have determined that someone is having a lot of adjustment problems, is not functioning well, and you want to find out why, you really want to focus on the extreme levels of those traits. Okay, you want to really say who is really low in agreeableness, who is really low in extroversion, who's really high in neuroticism. And the standard measures we use to assess the big five are just not built for that. They're not really designed to really focus on the extreme end of the scale. So anyway, that top scale there just shows like your typical measure where we're interested in. If we had a 9 point scale, where people fall on that scale. Are they a two? Are they a three? Are they a four? Are they a seven? Okay. But for measures of personality disorders, we only really care about the extreme end of the scale. That's what we want to focus on. We don't care if someone is like moderate extroversion or very extroverted or moderately agreeable or very, that's all fine. That's good. But what we want is a measure like the one at the bottom. And the reason 7, 8, and 9 are in red is just to emphasize that it's a measure that really focuses on the endpoints of the scale. Um, all right. Let's see. One thing I should show you though is so okay, you know more about the trait measures, but um, remember uh, another thing that you measure is what's just called general level of impairment in self and interpersonal functioning. Okay, and presumably if you don't have a score on that measure that suggests you're having problems, we don't even bother with criterion B. So there is a measure called the level of personal functioning scale, self-report version. I think there's also a version that like a psychiatrist or psychologist rates you on. Okay, and this is just 20 of the 80 items on that scale. That's a lot of items, but look, if you're going to diagnose someone with a personality disorder, you want to be very careful. You want to make sure you know what you are doing. Um, so it's a long measure, and you can see there are items on there. Let's see, though I try, I can't seem to keep any successful, lasting relationships. Okay, so there are questions about problems in relationships. Almost no close relationship turns out well in the end. Okay, then there are other items like um, although I have different feelings at different times, I can handle all of them pretty well. Well, if you say not, then, maybe you're struggling. Um, let's see. I can't even imagine living a life that I would find satisfying. And if you agree with that, that suggests you're probably pretty unhappy. Okay. So, anyway, now you might be thinking, and if not, what the hell? I'll just throw the thought into your head that some of these items here, sure, they get at just generally feeling bad and doing poorly in your everyday life, but they also look like they could be measures of some of those traits we just talked about, right? Um, like, although I try, I can't seem to keep any successful, lasting relationships. Kind of sounds like it could be a measure of detachment also. Anyway, that is true, and that is an issue that people discuss. But you don't really have to remember that. I'm not requiring you to remember that. The point is just that we have a separate measure that's almost like the screening measure. Like, are you doing poorly? Are you not functioning well? And it's a measure that looks like this. Well, okay. So again, just to contrast, we've got the classic way of thinking about personality disorders. You got lists of symptoms and you try to figure out, does this person have a dependent personality disorder or a borderline personality disorder or a schizoid personality disorder or whatever it is. And then we have this other approach where we just directly look at how bad people are doing in their day-to-day life and in what ways are they struggling? What traits do they have that seem to be leading to their issues? So there's a lot of argument over which approach to use. And there are some psychologists, some therapists, some people who, work with those with mental health disorders who say that this new approach, it makes sense. Um, there's a lot that has going for it. It maybe will help us avoid those problems that we have with just arbitrarily deciding that 4 of 7 symptoms means you have a personality disorder. But there's still some resistance to changing to this new system. So this is just the last thing I want to tell you about this. Why this new system is not popular with everyone. Okay, and basically it boils down to it might be difficult to use in actual clinical practice. Okay, so some authors pointed out a diagnostic system should be simple enough to be used by busy clinicians, including those who do not specialize in the assessment and treatment of personality. So it's true, using this new method requires you to know a little bit something about personality assessment and to know how to administer and score certain measures. Um, Not all psychologists have that training. Of course, the rejoinder to that is maybe they should have that training. But also, as you might imagine, administering all of these measures and coming up with unique profiles uh, is probably a little more time consuming. And in the end, the diagnosis you get, it's a little more difficult to know what to do with it than the old diagnoses. Okay, these critics also say a clinically useful approach should focus on types of people, not types of rating scales. Okay, um, it sort of leads people to not focus on the whole person, but to just focus on discrete aspects of their personality. And that's not something that clinicians are used to doing. And it's also debatable over whether that's a good thing or a bad thing. Okay, and just going along with this, it says mental health professionals think in terms of syndromes or patterns. It's true. Uh, you're this kind of person and you should get this kind of treatment. Not in terms of deconstructed subcomponents or in terms of 30 plus separate trait dimensions to be rated. Now you might say, what is this about 30 trait dimensions? I thought there were 5. Well, you could break those five down into six sort of like sub-traits. So actually, the measures can be very complicated. Okay, so anyway, um, one way of looking at this conflict is that um, there are people coming up with a system for assessing personality disorders that is just not very practical to use for actual psychotherapists and clinicians. Another way to look at it is that, well, it just so happens that most psychotherapists haven't been trained to use this system. If we train them to use the system, then they will be comfortable with it. I'm not going to take a stand on that debate. Uh, but uh, but anyway, it's unclear what the future will hold and which system will win out. Okay, well, listen, one final brief topic. No more separate mental health disorders. We're done with those. Uh, no more lists of symptoms. But there's one issue that is sort of a general issue that applies to everything we have covered this semester. And we've touched on this a little bit, but I'm going to start by showing you a video to introduce the topic and um, say much of what needs to be said about the topic. So here we go.
Consider that statistically speaking, you are one of those people that you just shook hands with will likely experience a mental illness at some point in your lifetime. 43.8 million adults experience mental illness every year. That's a high prevalence of mental illness. Yet, why is it something we're still afraid to talk about? In October, everything is pink for breast cancer. In November, men grow out all their facial hair for prostate cancer. It's a great excuse for this guy not to shave. We go to galas, we go to golf tournaments, we go to 5Ks, we go to fundraisers and more for heart disease, cancer, and many other illnesses. And while all of these are important, we often forget or don't realize that mental illness is among the #1 cause of disability in our country, costing nearly $200 billion in lost wages annually. Depression, #1 cause of disability worldwide. Suicide rates continue to climb among adults, adolescents, and even children. Every year, we see the loss of celebrities and prominent figures to suicide. The opioid crisis continues to devastate our communities, costing over $100 billion annually. Yet, we're still not courageous enough to talk about mental illness. Why? Think back to shaking your neighbor's hand. Think about some of the first thoughts that came to mind. Great dress, cool shirt. Hope there isn't any more audience participation. Now, how did your thoughts change when I mentioned that one of you may experience a mental illness? Even for the most open-minded, judgment is a natural part of our human condition. However, when that judgment escalates to discrimination, prejudice, even hostility, it becomes a breeding ground for stigma. Stigma, defined as a mark of disgrace as a result of stereotypes and misunderstandings. In our society, mental illness is stigmatized more than any other illness or condition. We can see examples of stigma every single day, and we might not even realize what stigma looks like. Read the news. Turn on the news. Scroll through social media. Overhear a conversation on the street or at work. You are bound to hear an example of stigma. You might not even realize it. And those individuals that are stigmatized face barriers and obstacles to getting the help that they need. And it creates a bigger burden of untreated mental illness for our society and our healthcare resources. Now, some of this lies in a misunderstanding of psychiatric diagnoses. The brain, pretty cool, but very complicated. Modern science has still only just begun to understand how this works, let alone understanding what happens when there are issues with the brain functioning. There are many, many factors that contribute to the onset of mental illness: biological, environmental, social, genetic, stress, trauma. We still don't quite understand the interplay of all of these in our brain. Unlike back injuries, cancer, diabetes, we can't go get a scan. We can't go get an x-ray. We can't draw labs to diagnose mental illness. We can't see mental illness in the brain. Therefore, we have to rely on subjective reports and observations to get to a diagnosis. For many people in our society, this discounts the realness of mental illness. You can't see it. It must not be real, right? This also leads to a lot of misunderstandings that people with mental illness can control it or snap out of it, or that those people who can't are weak or lazy or stupid or have other personality flaws. We would never have these expectations of somebody with a broken leg or cancer. Now, all these stereotypes begin to form because of these misunderstandings. The main one is fear. We have seen mental illness become synonymous with danger, violence, instability, and aggression. This isn't what mental illness really looks like, yet this is the picture that's painted over and over again. News media sensationalizes violent events, often portraying those suspects as mentally ill, homicidal maniacs. Movies, television, social media, even video games all follow in line with these fearful representations of mental illness. How many movie villains have mental illness? Think about it. This leads our society to label and seek separation from individuals with mental illness, causing them to feel shunned, isolated, fueling their own self-stigma and shame about their condition. So, we also see this lead to issues with employment opportunities, housing options, and even relationships. And if these personal things aren't enough, we can see these false beliefs penetrate our legislature. We can see policies come out that put further barriers in place for people in need of help. Now, we also can see this happen in our healthcare system. Many medical providers and healthcare professionals have these same false beliefs, and these can carry over into the care that they provide patients with mental illness. So those patients might not get the diagnostic testing or the interventions or those referrals that they might need, because sometimes those medical providers think the symptoms are all in their head. And on a larger scale, sometimes we can see this stigma in the way that insurance companies cover or don't cover mental health care or psychiatric interventions. With barriers like that, it's no wonder that more than half of the adults that have mental illness never seek the treatment or care that they need. Now, here's the thing. Mental health care works. For every dollar that's invested in treating depression or anxiety, we can see a yield of $4 in health outcomes and ability to work. That's a pretty good investment. I don't do finances, but I probably would want my 401k to look like that. And people that do seek treatment for mental illness have good outcomes. They get good symptom management. We can even see remission. You may not even realize how many successful people in our society have or continue to battle mental illness. Now, there is a simple solution to breaking this cycle of stigma, at least the first step. If we as a community can talk about mental illness in a respectful and real way, we can start to break that cycle. Education about what mental illness is and what it isn't can challenge people's misconceptions and stereotypes. It can also begin to change people's misunderstandings. On a personal level, we can put aside our own prejudice and our own false beliefs and simply show empathy to those people and families that are dealing with mental illness. Doesn't take much. Now, if we, as a community, as a society, as individuals, can start to see people with mental illness as people rather than their diagnoses, we can take that first step to breaking that cycle. And we will also start to see that people with mental illness aren't any different than you and I. The first step is having that courageous conversation. So, isn't it time we stop the stigma? It may just start with a handshake. Thank you.
All right. Um, so, by the way, you may have noticed her comments about people's exaggerated belief about the association between like schizophrenia and violence. And we've talked about that in class, how, in fact, um, someone with that kind of mental illness is much more likely to be a victim of crime than to be a perpetrator of crime. So that was, of course, a talk about the general issue of mental illness stigma. Um, and when it comes to different types of disabilities that people have, there is research that shows that people with mental illness are probably the most stigmatized group of people, meaning that people have the most reflexive negative feelings towards them, a lot of want to distance themselves from them, to reject them. So you see, there's a whole bunch of possible issues. People could have diabetes, arthritis, asthma, cerebral palsy, and you know, the arrow. I hope I'm back. I think we lost connection there for a minute. Oh boy. Okay. So, where was I? I don't know when I got cut off, but here again is a chart showing groups of people from least stigmatized to most stigmatized. And you can see mental illness is at the bottom. It's the most stigmatized group of people. And by the way, I know one of the labels on there is mental retardation. Um, Today, we would probably label that intellectual disability. This is a table from 1988. I'm sure the data are still just as valid today, but yeah. Um, okay, now, so people with mental illness are the targets of prejudice and discrimination, and people have all sorts of disparaging, unflattering beliefs about them. What are those beliefs? Well, there are, of course, a lot of them. And it depends on the kind of mental health disorder that people have been exposed to or are thinking about. But for the most part, the main stereotypes associated with people with mental illness are incompetence, okay, basically low ability, uh, low ability to get things done, not being able to solve problems or complete tasks, um, being unable to care for the self. Okay, that's another of the stereotypes. Childlike, which is kind of similar to those other two. And finally, dangerous. That, of course, is another one that we have talked about up to now. So obviously, people don't think the same way about depressed people or people with schizophrenia or people with post-traumatic stress disorder. But in general, regardless of the mental health disorder, this tends to be uh, what people think about those with mental health disorders. Now, where do those beliefs and attitudes come from? That's a big question. Okay. And look, they might come from interpersonal experiences that people have had. But as the woman in the video pointed out, um, a big source of these attitudes and beliefs is the media. And yeah, she alluded to this kind of thing, but here's some actual numbers for you. Uh, Years ago, between 1985 and 95, Hollywood released more than 150 films with characters with mental illnesses, and the majority of them were killers and villains. Okay, 1991, these researchers found that 86% of all print stories dealing with former mental patients, so in other words, not movies, but even news reports, focused on violent crime. Um, and, in case you're saying, well, that was a long time ago, how about today? Well, more recently, characters with mental health conditions, uh, between 2016 and I think 2022, um, 46% of the characters were linked with violence, uh, and actually, according to this study, if anything, the numbers are going up. Oh my gosh, 63.4% in 2019, 72% in 2022. So, 72% of people with mental illness being shown as perpetrators of violence. And in addition, nearly 80% of these characters with mental health conditions experience some form of disparagement on screen. Now, I don't know, maybe some of these were movies where somebody was disparaged, but then later that person learned that they were wrong and got their comeuppance. I'm not sure. The important point is that if all you know about mental health disorders is what you see in the media, uh, this is uh, this is what you will see. And so it's not surprising that people have these stereotypes. All right, well, I probably don't have to convince you that stigma is a bad thing. But just to be a little more specific about why, I mean, it's more than just that people who are stigmatized feel bad and feel bad about themselves. It's not just that. It's not just that it's mean to stigmatize people. Um, this is just a partial list of why stigma matters, what the consequences are of people who are a member of a stigmatized group. There's employment discrimination, housing discrimination, limits on educational opportunities. In other words, admissions to college discrimination, um, insurance coverage. That's always a constant battle, trying to get parity between mental health disorders and physical illnesses. And then, of course, yes, direct interpersonal rejection. Okay, now I just want to just for a second point something out. I don't know if any of you have had this thought, but I know when I see data like these or, claims like these, a thought comes to mind to me that, okay, so let's say you have to hire someone for a job and one of your applicants is uh, been diagnosed with schizophrenia and is floridly hallucinating and, having thought disorders. You might say, well, yeah, probably I'm not going to be hiring that person. Okay. Or uh, somebody who says, I'm so depressed, I can't get out of bed. Yeah, probably you won't be admitting that person into your school. Um, so clearly, the whole reason that we call mental health disorders, is that, they get in the way of people's functioning. And so no one is denying that. The point is that the stigma we're talking about is to people who have had a mental illness. What we're talking about is the exaggerated sense that people who have ever had a mental health disorder are now somehow untrustworthy, childlike, possibly violent, aggressive people. Um, that's what we're talking about. Okay. And, there have actually been studies showing that, people who've recovered from certain mental health disorders are no less reliable employees than anybody else. So it's a complicated issue, but what we're talking about is sort of the intense stigmatization of ever having been diagnosed or having been labeled with a mental illness. Now, another reason that stigma matters is that, again, who wants to be stigmatized? Who wants to be labeled as a person with mental illness, given everything I've told you? Um, well, as a result of that, people who need mental health care might not seek it out. Okay. Um, and why is that? Well, because they know that, they could possibly be stigmatized for being seen as somebody with mental health issues. Okay. In other words, people have stigma expectations, which is the sort of extent to which you think most people will devalue and discriminate against a mental patient. Okay. So you can see how this would inhibit somebody saying, I just don't want to be labeled in a certain way. Um, So they're concerned about the stigma they'll experience if other people find they have had mental health issues. And by the way, it's even worse than that. There's also something called courtesy stigma. Okay. And what is that? Well, it's the fear that, if you're seen as somebody with a mental health disorder, not only will you be stigmatized, but maybe people close to you, like your family. Okay. And, it's true. It is possible that, being someone who's known as, my children had a mental illness could lead people to have questions about you, uh, and to stigmatize you. So people with mental health disorders are sometimes reluctant to seek out help because they think this is going to like tarnish my entire family or all my relationships. So that's kind of depressing, I realize, but I just want to finish with one piece of good news, which is that yes, there is stigma. It's a real thing. People with mental health disorders are stigmatized, but our stigma expectations are often exaggerated. We overestimate other people's mental illness stigma. Okay? It's a real thing, but people, I think, are unduly inhibited about seeking out help because of their beliefs about stigma. And uh, I know that because I had a student who, a number of years ago, ran a study where Syracuse University students were asked a bunch of questions about their willingness to use mental health services, like I would want to use mental health services if they were experiencing problems in my family relationships. So she got data on people's willingness to uh, seek out help. They were also asked about their own mental health service use stigma. Okay, like, do you stigmatize people who have sought out help? And they had to say if they agreed or disagreed with statements like, I would willingly accept someone who has received mental health treatment as a close friend. All right. So we learned about their own willingness and uh, their own stigma. But in addition, they were asked to estimate how other Syracuse University students would answer those questions. So, what do you think? What are your expectations about how other people would answer those questions? And what she found was that people, first of all, significantly underestimated other students' willingness to use mental health services. In other words, people believe that, yeah, most people are inhibited. And they also overestimated, to a very large degree, the extent to which other students would stigmatize someone who sought out mental health services. So, again, people are worried about the stigma, and it's a real thing, but people have exaggerated beliefs about the extent to which others would stigmatize them. And also, they underestimate the extent to which, yeah, people will actually seek out help if uh, they are feeling they're having adjustment issues. And by the way, this overall pattern that I've just described about mental health stigma expectations is an example of something called pluralistic ignorance. So, pluralistic ignorance involves mistakenly believing that your own attitudes and beliefs are very different from other people. Okay? And there are lots of examples of this kind of thing. Like, just so you know, um, there's a lot of data on binge drinking on campus. Students overestimate the extent to which others uh, approve of or are comfortable with binge drinking, and their own behavior might be affected by what they think other people's beliefs are, but they're wrong about other people's beliefs. So, yeah, an example of pluralistic ignorance, just a bunch of people collectively not knowing what's going on in other people's minds and having an incorrect picture of what other people think and letting that affect their behavior. Okay, let's see. I'm gonna skip this next slide because it's not necessary. And instead, all right, let me at least take 10 minutes to go over the notes that I sent out. All right. And look, we started out by talking about substance use disorders. Okay. And look, maybe you remember that mental health disorders can be comorbid with each other, but probably the most common comorbidity involves substance use disorders. Because it seems like whatever other mental health disorder you have, it causes stress. People want to relieve their stress, and they often turn to alcohol and other drugs and substances. So it's very common for that to be comorbid with other uh, mental health disorders. All right, but in order to get a substance use disorder, you have to know how to diagnose it. Please take a look at uh, your notes for those criteria. Um, Now, you know, often, hopefully, uh, people with substance use disorders often try to stop using that substance to, go cold turkey, to uh, wean themselves off of drugs and alcohol. And weaning yourself off of alcohol, if you're an alcoholic, is particularly difficult. And there are all sorts of uh, things that happen to you and all sorts of distress that you feel. But in the worst case, you get what are called delirium tremens. So once again, you can read about that in the notes, but again, it is a really negative side effect of withdrawal from alcohol. All right. Now, Again, I just said that people use substances to help relieve themselves of distress. Uh, does it work? Does alcohol, for example, help you feel better? Well, maybe sometimes it could make you feel worse, or sometimes it could actually make you more agitated and make you like lash out at other people. So when does it calm you down and when does it just make you feel worse? So I told you about something called alcohol myopia theory, and I even described a classic study about alcohol myopia theory. So um, you will find that in your notes, and just to point you in the right direction, one of the key things is just how distracted you are when you consume the alcohol. You know, immersing your attention in some other activity, distracting yourself, is a key variable when it comes to understanding the effects of alcohol on mood. All right. Look, we talked about different classes of substances that could lead to a substance use disorder. And opioids was one of them, things like OxyContin. And you'll remember opioid addiction is a major problem in society, and it's difficult to get off of opioids. And there are withdrawal symptoms from stopping the use of opioids. Um, Hallucinogens, things like LSD, psilocybin. One thing about them is that they're not as obviously addictive as other drugs. And you don't get the kind of withdrawal symptoms from stopping the use of hallucinogens that you get from other substances. But in extreme cases, you can get something called hallucinogen persisting perception disorder. So look that up. But if you've ever heard of someone having an acid flashback, um, that's basically uh, an everyday term for someone experiencing the symptoms of hallucinogen persisting perception disorder. It's not that common, and it really, is a function of extremely high levels of hallucinogen use. Okay, then our next topic, schizophrenia. And you should know the diagnostic criteria. And you should know that when we talk about the positive and negative symptoms of schizophrenia, we are not talking about the good side of schizophrenia, positive, and the bad side, negative. Uh, no, positive and negative symptoms refers to something else. Okay, and you can read about it, but for example, hallucinations, that's one of the positive features. Um, Becoming catatonic, that's one of the negative symptoms. All right, well, again, there were other psychotic type disorders, and one of them is schizoaffective disorder. And yes, I know it's confusing. We have schizophrenia, we have the schizoid personality, we have the schizotypal personality, and we also have schizoaffective disorder. But yes, you should know the differences between them. And, look, as you probably can remember, schizoaffective is a less severe form of schizophrenia, but read up about that. Obviously, a big question is what causes schizophrenia. And I went over a theory that is now very much discredited. I'm almost sorry I went over it, but there was something called the refrigerator mother theory, which basically meant blame mom. Um, you should check that out. Um, what are some of the instead, it's kind of understood that when it comes to schizophrenia, really the main thing are biological causes. So you should look at what we said about the genetic transmission of schizophrenia. That falls into this category. To what extent is schizophrenia heritable? However, we also concluded that even if schizophrenia is very biologically determined, that doesn't mean that life experiences don't matter. That doesn't mean that having experienced stress is not something that could trigger schizophrenia. Okay, and that leads us to the diathesis stress model, which basically says that usually it's an interaction between those two things. Having a genetic predisposition to a psychotic disorder and experiencing stressful life events that actually trigger it. Now, when it comes to treatments for schizophrenia, you know this semester I have not been asking you to memorize names of drugs, but the phenothiazines play a very important role in the history of treatment of schizophrenia. I mentioned them in class. You can find a discussion of phenothiazines in your reading as well. Well, look, we're almost up to date. You should know the basic description of the 10 personality disorders. And though I said they overlap, they really are distinct enough so that it's not so hard to remember their definitions. And with some of them, the name pretty much shouts out the definition of the personality disorder: paranoid personality disorder, dependent personality disorder. Okay, it doesn't take much to figure out, for example, what those are. Okay, all right. I'm not sure I will ask you to remember which cluster each of the personality disorders goes into. I'm not sure that's important, but you should at least know what the three clusters are. Okay, now something else you'll find in your notes, pretty straightforward. Which personality disorders involve the biggest gender differences? All right, check that out. And then, oh, look, we're getting up to today. You just heard twice why the DSM approach to personality disorders has been criticized. Not much more I have to say right now. Um, And you learned today what are the two criteria proposed for this alternative approach for conceptualizing personality disorders. Remember, criterion A and criterion B. Criterion A is just how much trouble are you having? How dysfunctional are you? Criteria B being, well, which are your maladaptive traits? And finally, obviously, stigma was just a short part of class, but hey, um, you should remember what the main stereotypes are associated with people with mental illness and what effect mental illness stigma has on people's decisions about whether to seek mental health treatment. Frankly, that question almost answers itself, but recall what we said about that. And finally, this last thing I told you, remember that there is stigma. It's not made up, but that we tend to have unrealistic stigma expectations. In other words, exaggerated beliefs about others' stigma. I'd like you to remember that as well. All right. Finally, I assign reading. Of course, I want you to do the reading. And a lot of the reading reinforces what we've gone over in class. So you're going to really know this stuff if you've done the reading. But as always, I have highlighted a few sections specifically because, for the most part, these are sections where it's important. I think someone taking a class like Psych 395 should be exposed to this and know about it, but I didn't really have time to talk about it in class. I didn't say much about amphetamines other than that they're stimulants. Take a look at that section. I didn't say much about cannabis other than say it's a very complicated drug. You want to look at that. As always, sections on multicultural factors. I unfortunately think I underemphasize those in class. Thankfully, we have a textbook that discusses uh, those issues. Okay, when we talked about psychoses, we didn't talk about postpartum psychosis, which is a real thing, and as it says here, a dangerous syndrome. Okay, there's another section on hallucination reinterpretation and acceptance that I think you might want to take a look at. We did talk about something similar to that in class. All right. And finally, the last thing I'm listing here, personality disorder, trait specified, but basically that overlaps with what I talked about in class today. But I think understanding the alternative approach to assessing personality disorders is complicated enough that I did the best job I could in trying to explain it today, but you might want to read that section as well. Other than that, same drill as last time. All right, everybody. Uh, I hope you all watch this, and good luck on the test on Monday. If you have any questions, uh, please let me know. Uh, Take care.